I invite Drs. Jeyaraj Pandian, Dr. A.T. Prabhakar, and Dr. Yogesh Kolkonde for moderating the session. The discussion on equity in health and addressing health disparities tend to be abstract. How do we bring equity into the discussion of the processes of history taking, physical diagnosis, clinical management, and prevention? In this session, we will be asking experienced physicians to discuss their approach to equitable healthcare in relation to concrete case problems. The aims of this session are to highlight social and cultural understanding and patient perspective of their illness, clinical approach to cost-effective management, history examination diagnosis, lab tests, choice of therapies, and how to apply evidence at the bedside to ensure equitable care. Over to you, sir.
Good evening, everyone. I'll be presenting a clinico-social case. So I'll be presenting Mrs. R, a 38-year-old housewife who stays in Katpadi, actually just next to the railway station. And the respondents, when I interviewed, were the patient and their family. So the family details. So I'd just like to start by putting this whole case in context. And before I start, I'd just like to say, so when somebody comes to us in the hospital, what we usually say is start from the day that the illness started and everything. And one of the things I learned through this is that an illness is actually an interruption. So unless we put that in context, I think we'll never put the illness in its complete entirety. So the next few slides will be about the daily life and the situation that this lady comes from. So this is her family. What I've outlined in the dotted lines is her immediate family who stay together. She is married and she has two daughters, and they stay together in this house in Katpadi. The interesting thing is her elder brother and sister also stay just adjacent to each other. Actually, they all stay together in three adjacent houses. So socioeconomically, her husband has finished his 10th standard. He works as a sweeper in the corporation in Vellore with a monthly salary at the time of stroke of 6,500 rupees per month. Now, the thing is that it's important to note he is a contractual worker in the corporation, so he doesn't enjoy most of the benefits that the other state corporation workers enjoy. And her brother, who's also a sweeper working in the corporation, is not a contractual employee but a permanent employee. So he enjoys all those benefits. The patient herself has discontinued education after her 7th standard. She's a housewife. She doesn't have any source of income. Their modified Kupasamy score is about 9, which puts them in the upper lower class. So coming to the housing details, again, these are all the specific details of the house. But before we come to that, they were originally staying in Bangalore, where the cost of housing was too high for them to afford. Now, the husband's mother had actually put aside some money for him, which she gave him. And the wife's brother and sister had a piece of land, which is actually Porambok land, as they say. It's not notified from the government. So they had a little excess land. And so that's how these people came to stay in Vellore. The husband had the money to build the house, and the wife's relatives had a small plot next to theirs, which was actually available. So they actually kept sending money from Bangalore initially, and once the superstructure was constructed, they moved over here. So their house actually has an asbestos roof. It has a single window at the back with no netting. There's an outdoor kitchen area which is covered by the same roof, but it's outdoor, where they have a gas stove. And the grinder, which was given by the social scheme from the government, they got the grinder free, and they get drinking water from the nearby borewell. They have a single room in the house with one cot and TV with an electricity connection, which is they do pay for that electricity, and they have in that same structure under the asbestos roof an outside bathroom with an Indian toilet and an attached water pipe. The sullage from the kitchen and the sewage from the bathroom drain into an open drain in front of the house, which just across the road from their house there's a large open sewer into which all these things drain. And another important point I wanted to highlight was that these three houses are in continuity. So her elder brother, her sister, and then her. So coming to how they were spending their money, the 6,500 rupees that the husband earned, of course, a vast majority of it went in food. They did have a ration card. They did get some basic food from the government, but they did buy non-veg maybe about once in 1 or 2 weeks, and the other necessary food grains. So that's where a vast majority of them went. The education 500, the two daughters actually studied in a government school where the education was free. but they did have to buy their uniforms and their books. So that took about that 500 rupees a month went roughly there. The elder daughter actually at the time of the stroke had gone on to study in Buddhist College, which is in Vellore. She was doing her BA in English. Before the stroke, actually, she discontinued her education after completing her first year because she couldn't afford the fees. Um, the other 1,200 was for the gas. So I'd asked them whether they actually get the benefits from the government of the subsidy on the gas cylinder. So they do, but they do have to pay for transporting the cylinder from the station because this land is not notified. The cylinder is not delivered to their house. So it comes to about 750 to 800 rupees approximately a month, and they pay about 300 rupees for the auto to actually bring the cylinder over to their house. The electricity is 800, which depends. They share it with their relatives, so that's the thing. And the miscellaneous expenses are 1,000 rupees. So this is actually what they would use on any form of entertainment that they would have or anything else. The husband said he initially used to consume a lot of alcohol, maybe once or twice every 2 to 3 days. But as the expenses mounted, the daughter's education, everything came up. He actually reduced this to once in 2 weeks or so. He spends some money on alcohol, and they do occasionally go for a movie in some small theater or something. So that's where the remaining 1,000 goes. So this is the context into which actually, so the stroke of misfortune, as we say, happened. So on the 11th of November 2021 at approximately 9 p.m. So they'd all had dinner at around 8:30 and gone to bed. At approximately 9 p.m., they noticed that the mother was vomiting. That's all that they knew. And the light was off. So when they switched on the light, they noticed that she was actually altered. She was not moving the right side of the body because she was flailing the left side a little bit, but she was not responding to what they were saying. So ironically here, this is where all their social structure made a lot of difference. The husband actually went out to call an auto rickshaw, and because they lived just next to the railway station, even at this time of the night there were plenty of auto rickshaws available. So he brought one over, while her elder brother, who lives 2 doors down, actually came down, and he had to lift her up and take her to the auto. So together the two of them lifted her up and took her to the auto rickshaw. She was completely altered at the time, not verbalizing, not responding to anything. So from there, they actually went to a local clinic where they were immediately told in the auto rickshaw itself that nothing can be done, take her to a larger hospital. And then they decided to come to CMC. So this is at the time of presentation to CMC. She was conscious by then. She recovered consciousness somewhere in the auto, but she was not oriented to time, place, or person when examined in the ED. She was drowsy. Her BP at that time was found to be 220 by 120, and her pulse and the rest of her vitals were normal. The rest of her general and systemic examination was unremarkable. Her GCS was 14 by 15, and her pupils were anisocoric at the time. Her extraocular movements were full from what they were reporting, and her corneal reflex present, gag reflex was present. The motor, the right upper and lower limb powers were 3 by 5. The reflexes were absent on the right side, and the sensory system could not be assessed due to her altered sensorium. So the medical diagnosis made at the time of presentation was an acute stroke with a clinical localization to the anterior circulation with the left hemisphere, probably the posterior limb of the internal capsule due to the dense hemiplegia that she presented with. In view of the elevated blood pressures, the etiology and the stroke, which was maximal at onset and subsequently improved, the etiology was thought to be probable secondary to hypertensive bleed. The imaging was consistent with the same. She had an acute intraparenchymal hemorrhage involving the left capsular ganglionic region with minimal edema and no significant midline shift. So the risk factors identified at that time were that she was a newly detected hypertensive because her ECG, which I'll come to, showed actually LVH with strain pattern, and dyslipidemia and diabetes, which were later diagnosed through the causes of admission. And through which I'm just briefly touching on all these, through the hospital stay, which was for a total of about 20 days, she developed a catheter-associated urinary tract infection, and the blood and urine cultures grew Klebsiella, which was hospital-acquired. But thankfully, it was susceptible. So she received 3 days of meropenem, and once the susceptibility reports came, it was downgraded to ciproflox. So her investigations at that time revealed a couple of other problems. She had an anemia. Her HB was 9.1. The MCV was low, and the iron studies on the right and the low transferrin saturation were all suggestive of an iron deficiency anemia. Her stool occult bloods and stool routine parasites were negative. It was attributed to probably nutritional anemia, and she was started on iron supplements. The ECG showed an LVH with strain pattern, so she was probably a chronic underlying hypertensive which was undiagnosed. and acute coronary syndrome was ruled out. 2 sets of cardiac enzymes were normal, chest X-ray, and the other investigations were normal. In terms of her background workup, her HbA1c was found to be 9.4, so she was a newly detected diabetic. Her TSH was normal, and her lipid profile was deranged, indicating dyslipidemia. So, in view of the fact that she developed this hypertension at that time when she was 35 years of age, she actually underwent a secondary hypertension workup. The renal artery Doppler, the vasculitis workup, the urine metanephrines, normetanephrines, everything was negative. So, it was attributed to possible essential hypertension with associated risk factors of dyslipidemia and diabetes. So, coming back to what actually happened to this family. So, they paid about 250 rupees to come by the auto rickshaw from their house, first to the local clinic, then to CMC. And in ED itself, including the CT scan and the initial medications that she was administered and everything, the total cost was about 20,000 rupees. So that's just the first part. So how did they actually manage this? That elder brother who had come with them, actually, because he's a corporation worker, his salary is about 20,000 because he's been working along and he's not a contractual employee. He had about 25,000 rupees saved up. So he gave them that money. So that was the first amount of money that they received, of which they spent 20,000 rupees straight away in ED itself, and they paid the remaining 5,000 as advance for IP admission. The next morning, the daughter who was engaged at that time, her would-be in-laws had come to visit, and they gave her 5,000 rupees. And the husband's mother, when he contacted her, had also given 5,000 rupees. So for the next so many days, they had to manage on these 10,000 rupees. So the total IP bill, along with a few little bit small amounts that came from immediate relatives and some few minimal salary that he had left over. So the total IP bill at admission was at discharge was 1,01,000 rupees, and the approximate cost of medication was about 30,000. So the IP bill was written off, and the medication cost was what they finally paid. So they had to keep buying the antibiotics for the UTI, the NG tube, the catheters, and all those things. The food, they were actually cooking food at home and bringing it, and they were bringing it by the public transport, which cost about 7 to 8 rupees at that time for a daily commute. So the daughter and the husband alternated taking turns. One would stay at home and cook while the other stayed with the mother, and they'd bring the food and then hand it over to the next person and go back to cook. So that's how they managed. There was lost income for the husband because him being a contractual employee, he was only eligible to take 2-3 days leave with permission. That was also not official. Following which they said that ideally, even for his contract, he's supposed to receive full pay if he can demonstrate a valid reason for this. But he said that his superiors at work said they'll give him half pay and take the full month, or that he can leave the job. So he took the half pay option, and he got half his salary for that 20 days that he worked. So after 20 days, the lady was discharged and then lost to the system for 2 years. They did come for a few OPD visits for about 4 months, and then they stopped coming completely. And then I went and saw them about 3-4 days ago. So what is their current situation? So she currently has minimal residual paralysis with weakness of the right upper limb. She has a weak hand grip, and she's unable to extend her elbow or raise her arm above her shoulder on the right side. But her lower limb has had near complete recovery. She's able to walk, ambulate on her own, use the toilet, squat, all those things. And her facial paralysis had also significantly improved. She's independent for all activities of personal hygiene, but she is unable to cook or contribute to household chores, a lot of which is because they believe very socially that you cannot handle food with your left hand as per their cultural beliefs. So because her right hand is not working, she completely does not take part in any of the usual things. She does take part in social activities, goes for weddings. So interestingly, the daughter got married over these past 2 years. And so I asked him how the finances for that came along. The husband's mother had saved up for a plot of land, which was the only inheritance that she had to give him. And this plot of land was in Vellore on the outskirts. So the actual land price of that land, the value at the time of sale would have been about 3.5 lakh rupees. But because the daughter's wedding and everything came rapidly, they didn't have time. So he did a distress sale and sold it for about 2 lakh rupees, 2,15,000. So of that 2,15,000, almost 1.8 lakhs I spent on buying the jewelry and all the expenses, and the remaining 25-30,000 went on spending for the wedding, putting up the pandal, ordering the food and everything. So that was their only long-term asset which was left, apart from the land that they live on, and that was sold for the elder daughter's wedding. So the family has come some distance since then. The elder daughter briefly got a job. So she worked in a local mobile shop for a month, and she got the first monthly salary of 5,700 rupees. So I asked him what they did with that. She said that she was sure that she'll continue to get it. So she said, I wanted to buy a mobile phone. So she bought the only Android phone in the house. The other two use a button phone even now. So unfortunately for her, the very next day, something happened. I think the pandemic had something to do with sales, and the shop shut down, and she lost her job. So the only asset that they got from that monthly salary was that one Android phone at home. The husband continues to work. His salary over the past few increments has increased to about 9,000, but their expenses have proportionally increased because now he has to pay for medication and all those things. And the younger daughter, who is studying at about 8th standard, then continued for some time and then discontinued school, saying, I'd prefer to stay at home and take care of my mother. So that's where the family has come so far. So coming to the socio-economic determinants of health. So I just want to play a short video clip. This is taken with their permission. This is their one-room house with the asbestos roof and this thing. And I found this very So this actually came about. So what happened is that they stopped coming to OPD after about 6 months of follow-up, because the total cost of taking the auto to and fro was coming to almost 500 rupees, plus the OPD charges, plus the medication was coming to about 2,000 rupees, something that they couldn't afford. And they had learned the physiotherapy exercises by then. So they were religiously continuing it at home. And she actually recovered her foot function and her face and everything else returned. So the husband was watching TV one day when he saw some exercise video, and something clicked in his head, and he said, what she's unable to do is lift her hand above the forehead, above her shoulder. So what he decided was, he said, if I attach a pulley to the roof, I might be able to get her to do that. So he went to the local market and bought this pulley for $100, and he actually put it up on the roof of their house. And they actually do this now. He's tied a rope across it, so he uses a powerful hand to actually lift the non-moving hand, the dominant hand, actually over her shoulder. Of course, after the daughter's wedding, and she recently delivered, that's the baby. I don't know if you can see at the background there. So the only netting that they have in the house is that one cover sitting over the baby in the background on the cot. And so she stopped her exercises, but prior to that, she was actually quite regular with this particular exercise that they devised by themselves. So what has been my learning from this case? I realized that, like I started off at the beginning, this was an interruption in the life of an otherwise normal family, something which I definitely did not have a perspective of. For me, their entire life is summed up from the moment they've come to the ED and we've seen them and we've discharged them. That's the end of our interaction. At the most, an OPD, a brief visit. But this is definitely not what you would consider normal. I mean, normal is what all of us have on a daily basis. And this is an interruption to that normality. And so I was looking at what was actually helping them. The good social support. So the fact that her brother lived just 2 doors down and that he had cash reserves of 25,000 rupees. Now, is that really good? Is an interesting question, because now they're not on talking terms anymore. The brother said, it's been 2 years down the line now, and you've not repaid that 25,000 rupees. I agree it was for a crisis, but you should have made some provision to repay it. And so the husband said, all that we had was that one piece of land which we sold, and then the current piece of land that they live on, they're not sure if anyone will buy it. It's just next to a large sewer, and it's opposite the railway station, and it's technically not notified, so they're not sure when the government will do. The other thing was a very, very, very positive outlook on life. They were very resilient, these people. They were like, she's back to normal, she's quite well, and we're otherwise doing well. I take her to a local clinic because I can't afford to come all the way there. We're controlling her BP, we're controlling her sugars, we're doing everything you told us to do, and it's working. Which is quite strange, because my personal, prior to this, and I was recently posted in neurology, prior to that, my view of stroke is that it's a death knell diagnosis. You just do something for them temporarily and send them home. Nothing more you can do. And that's the thing. So what were the things against them coming out of this? So one was the low income, and the fact that that's really something that there's very little that they can do about, and nothing much has improved since then, simply because their income, along with the proportionate increase that has happened in his salary, the proportionate expenses have also increased. Their education, now that daughter, if she had just completed that BA, would have definitely gotten a lecturer's job or something with a stable salary, something with increment, something more. So that drop in education really hit them hard. Poor healthcare accessibility. So they live almost equidistant from the PHC and everything in Gudiyatham, the larger center, and CMC. So they live somewhere in between. Both ways, the auto will cost them about, at that time, 250. Right now, it's about 350 to 400, depending on the time of day, to go and come back. Even if the healthcare given there is free, they still have to pay for the transport to reach there. Now, the other thing weighing on their mind is this: the fact that they have a younger daughter who's unmarried and they have no viable sources that they can harness for her wedding. They have nothing left to sell. Is really weighing on both the parents' minds. That's their main concern. Actually, the illness, they've almost forgotten what the impact of it is. Their main concern was that. So I'd like to conclude by actually, I should have put a picture. I didn't get that. There's this Greek legend of Sisyphus. So he was actually punished by the gods because he cheated death twice. And the punishment is very interesting. His punishment was that he had to roll a stone all the way up a hill, and then it will just roll back down just before it reaches the top. He has to continuously do it, roll it back up again, and then watch it back. So I was thinking sometimes, with our patients and not understanding this context well like that, we may have helped them cheat death, maybe once, maybe twice. But now we have left them with a stone which they think they're just going to get out of poverty, and then it rolls all the way down again. And they have to start from the beginning, roll it all up again. One more event, one more thing. One daughter's wedding came, the only land that they had is gone. So I had asked them, I had said, did you ever consider that maybe when you sold that land, you could have kept a little and finished her education or anything like that? And so they said, now what's the point? Because even her husband, the daughter's husband, actually, all their income is funneled to his household. So if she had earned something also, the entire amount would have been funneled there. So they're like, there's nothing more that we would have got out of it. So that was my conclusion to the whole thing. That it was really rewarding to go and see them after 2 years and see where down the line that maybe the interruption to their life with us, and how little as a physician I can do to address their concerns right now, that really opened my eyes to that, and how pointless. Maybe they're not the only ones rolling the stone up the hill. I may have helped them cheat death, or the team that saw them may have helped them cheat death, but we've not accomplished much. And I'd like to say one last thing. On an average day in our casualty, if one of us is on duty, in one shift I see about 2 strokes that come in. So in a month, that's about 60 strokes. And they're usually the poorest of the poor. So if the 60 patients like this come in every month, and this is the end result at the end of 1 month, I think we've done gross injustice if we just stop with a couple of OPD visits and say we've done our job, we've dusted and done the very best. Yeah. So thank you. That was
Thank you. This is a typical scenario across the country. Whether you are rich or poor, when stroke affects, it affects the whole family. The joint family system, it's there, but in nuclear family, they feel the brunt. And so the rich, probably because of the resources that they have, they may reach the right hospital, they may spend, and then for rehabilitation, they may come to the OPD or may not come, but they can hire people, home care, and they can, at least to some extent, the patient will be taken care. But there are certain positive parts here. One is the social support you had mentioned. Second is the stroke, the hemorrhage. It's not very big. No, that's why there was a spontaneous recovery despite whatever fragmented rehab or whatever they would have received, and some advice, and they were able to innovate. That is India. This is our problem. We'll try to find some solution. So this is a good family support where they were able to innovate. This is a very a great example of what we call jihad or whatever. But it's amazing, how they were able to adjust to this situation. And so there are many advantages. Suppose the patient had moderate size hemorrhage and did not recover. Many of them die in 2 months' time. They can't take care of them at home. Bed sore, complications, an nasogastric tube, and so in that way, there are a lot of positive part of this patient. In terms of what the healthcare system could have done, let's say that this patient was not in Vellore, and the only place they can go is to the government hospital. And if they don't have a program there, they'll be just given some medicines, may not receive proper treatment, like the infection that you had shown, 2 weeks of antibiotics. She would have succumbed to stroke during at that admission. So, since CMCs and many of the Christian hospitals, we have this, mission to take care of these needy patients. And what else we could have done? Maybe one, our rehab team does this. The mobile you were talking about, the one Android, and many of them don't come back for rehabilitation. So like Dr. Prabhakar and me were just talking, and Dr. Sanjit, and the issues, how can we bring in innovative ways of delivering rehab at home. So one is videos, like, so the husband saw a YouTube video and then he prepared this, and so probably a video of some exercises that they could deliver at home. There's no need to come to the hospital, so they can avoid the transport cost. And since she had probably, I would say, mild to moderate hemorrhage, and that's why we can see the recovery. And in terms of rehabilitation, is a very good patient for rehabilitation, and a little bit of home rehabilitation with some support would have been very good. And so these are some of the things from the healthcare perspective. In terms of availability of medication, I think if they are not able to come here, then the best is health and wellness clinic or urban health centers where the government provides. And again, there are issues. They may get medicines for 1 month. The center may not have supply. So then they are stuck. So these are some of the solutions. I was just thinking about it, but this is across the country. Whether you're rich or poor, stroke, when it affects that family. It disrupts their routine, and particularly if somebody is in a hi-fi job and running a big company, it just disrupts everything. And somebody in low socioeconomic status, it really affects them and that entire system. And another thing from the caregiver's point of view, suppose the husband has a stroke, there's a caregiver, wife will take care. But if the wife has a stroke, then it's a problem. There's no one. That's a social system that we have. So that is another part. Probably there's a good family. They were able to take care of her despite all the differences. Putting in money, they cannot get back the money. And yeah, this is a typical situation that we face.
Yeah, thank you, Vineeth. That was quite an. You had given a detailed description of the family details, and so one of the common ways that when we as physicians working in hospitals who don't have access to all this information all the time, the biggest problem is depersonalization. So very often we treat the person who comes to us as a case or a patient, and we forget that they have feelings, emotions, friends, families, and people who care for them. And so one as a physician working in a hospital, living in an urban setup, I would look at it in this way, that we need to go through this exercise called repersonalization, or In this, basically, I would focus on three things: learning about the person's past, understanding their present situation, and planning for their future as a physician. So in this, I would have, so this is a classic example that every patient you see has got a story very similar to this, and it's much more complex than this. And so I would assume that this itself is just a narrative of the complexity of their social life. So as a physician, I would want to cultivate in myself and all the people that I train that every patient that you see, try to talk to them, treat them as a person, talk to them, address them by their name, try to understand their social setting. So your history should be so good that you're able to kind of mentally visualize their home, where they are, who's living with them, who's important to them. And that will sensitize you to the kind of how their life got disrupted. So it's not possible for you to visit all the patients that you see, but in your mind, you can have a mental travel of kind of figure out, okay, this is how the person is, this is their social support, this is their outlook on life at this point in time. And your medical knowledge comes in the current situation. So patient with a large hemispheric stroke comes, dominant hemisphere, you really need to decompress or not, depends on all of these social factors, family support, who's going to take care of the patient. And very often as a physician, making decisions in all of this information is very relevant, even in a hospital like this. And similarly, planning for the future, like not only decisions now, when to discharge, when to remove the catheter, when to start physiotherapy, all of this will depend on all the social determinants that you mentioned. So similarly here, so all patients, we would discuss this. Again, one aspect that I would look at is this: in our local population, we find that hypertension is generally much earlier onset. So the only thing I would have done differently is not spent a lot of money looking for secondary hypertension in this patient, try to cut down the duration of hospital stay, then maybe we would have avoided the urinary tract infection, and teach them rehabilitation, which they have actually learned. And this seems to be a success story because mainly, as sir had mentioned, it was a bleed and it was small and they had good social support. And so I would look at it, this is an eye opener that every time we see a patient, always look at them as a person and try to kind of repersonalize them and try to relive their lives in your head so that you can plan their present and their future.
Thank you. Thank you for that very excellent and comprehensive presentation. At least she was lucky to get brain imaging. The areas I work in don't even have brain imaging. So, but then, you know, one thing about stroke is this sense of nihilism, which is even is all pervading. You know, it's across medical care. We need not be that that nihilistic. So I usually put in a positive frame of mind what I can do to help this patient. So right now, and as you said, I mean, I agree with Dr. Prabhakar that I would have just done serum creatinine and ECG and no brain imaging in that area. I would have put the patient on statins and antihypertensives. But then I'll make sure that she takes antihypertensives because, you know, that's a huge thing. And, you know, one of the larger policy or advocacy issue becomes adequate control of hypertension. And we are very poor at control of hypertension. Do you know what's the percentage of patients with hypertension who are controlled in India? It's 10%. So 10% of total hypertensive patients detected and undetected are controlled. Secondly, there is physician inertia in terms of treating patients. So patient comes with a blood pressure of 150/90. Oh, okay, I'll change it next time. Next time 150/90, you don't put the patient on antihypertensives. So the relationship with stroke and cardiovascular disease with hypertension is linear, starting from a systolic blood pressure of 115. Right. So we really have to be aggressive in terms of treating hypertension, and so you can avoid such things. The other thing that we, I usually sort of try and do is what kind of benefits I can get this patient. So, I would have sent this patient to the disability office or disability board to get her disability certificate as early as possible, because sometimes if the patients improve, they won't get disability benefits. So try and get that disability certificate early for the patient. I would have referred the patient to, if the, cost of medication is a huge issue. So, one thing we do is send the patient to a medical, government medical center and have them receive medication. In terms of rehab, yeah, we commonly see this even in rural area. I remember an elderly patient with stroke. He didn't even have pulley. What he did is he just had this wooden roof. He had a wood. Then he took a sand bag and then just, pull the rope across, and then he was just pulling it using sandbag. So he had a gym at home, and, he recovered. So that's the other thing. The other thing I would specifically look for in the patient for stroke follow-up is looking for anxiety and depression. 1/3 of patients with stroke will have underlying anxiety and depression, and it could same be with the husband or spouse or other caregivers. So be sensitive to that. Ask proactively whether how they have. In general, I mean, all chronic diseases, I take mental health history. So make sure you prod into it, because sometimes and it's unearthed. So you're not addressing it at all. If patients are affording, you can put them on anti anxiety or anti depressant for some amount of time, but at least broach that topic, because then they like that doctor is asking about this mental health issues. Otherwise you never sort of broach it. So those are the things that I sort of look around. And as I said, that I also think at advocacy level, what can I do as an advocate? Sometimes we forget that as physician we're just treaters. So try and get out of that physician sort of, I call it step out of the room, and then see what you can do for advocacy. So as an internist, I'm a primary care physician, although I'm a neurologist. So advocacy is, again, send a message to people you are training. Tell them to control hypertension better. Tell them, secondary prevention. Make sure if patients have hypertension, diabetes are following, put them on statins because their cardiovascular risk is high. So those are the things that I would try and do, and at least give them some hope. Otherwise, if you are depressed, then patients also get depressed talking to you. So that's in brief.
Jeyaraj, Prabhakar sir, and Yogesh sir, for valuable comments. We have our next session in Hall A. It will be relayed here in Hall B.